Thank you very much. I'm about to engage in what I've learned is the worst form of education possible. I'm going to give a lecture, and I'm afraid you can't get up. Well, if you want to get up and move around, that's okay. I'm going to talk about milestones in pulmonary rehabilitation. I'd like to take you on the journey. That's been a very, very interesting journey, talking about the development of the field and observations that have extended our interest in the field, and just a couple of thoughts about the future. So I'd like to begin by reviewing some of the key studies that have contributed to the development of pulmonary rehabilitation. I think it's until about the turn of the millennium. And then studies that have extended our observations in the last 12 years, and then perhaps a couple of things about future trends. Well, in the 1980s, and that was before me actually, the pioneers in pulmonary rehabilitation were very confident that there was a modality of care that would work, but there was no formal evidence. And here's one paper actually published in 1969 by Tom Petty, in which he described a comprehensive care program for chronic airway obstruction, and in his description he included most of the modalities of care that we use today. Like any discipline, it cannot advance without some valid, reproducible and interpretable outcome measures. And so the growth of pulmonary rehabilitation was dependent on the growth of outcome measures, and the first was the 6-minute walk test. Actually, it was derived from a 12-minute run test used for military recruits to evaluate fitness rather than send them to a laboratory. And then it was modified in the mid-70s for a 12-minute walk test, and then in 1982 to a 6-minute walk test. And here, interestingly, you see the close relationship in the 12-minute run between the 12-minute run test and maximum oxygen consumption measured under formal circumstances. The development of disease-specific quality of life measures became very important, because then you could start to identify whether a training program would influence quality of life or not. And Guy described the chronic respiratory questionnaire. The left panel shows an example of this questionnaire for patients who are given adequate bronchodilator therapy. The right panel is from a different publication looking at the use of the questionnaire score for patients pre and post rehabilitation. The questionnaire itself is in 4 domains, looking at dyspnea, fatigue, emotional function, and mastery. And mastery is the extent to which you feel you have some control over yourself and your activities. And here's an example, a more up-to-date example of how the respiratory questionnaire has been used, in this case following lung volume reduction surgery. You can see the 4 domains in the 4 panels. You can see the 2 groups of patients, in white the ones who had volume reduction surgery, in red the control group, and shaded in is the minimum important difference, how much the magnitude of the difference you would need to observe to affect a therapeutic decision. Do you withdraw a treatment? Do you encourage a treatment? It is, in theory at any rate, the magnitude of change that could be detected by an individual patient. So we had confident pioneers in the 6-minute walk test and a chronic respiratory questionnaire, and then what I feel was a very important observation by Charles Emery, looking at the impact of pulmonary rehabilitation on the psychosocial conditions of anxiety and depression. So there are 3 patient groups, as you can see. Group 1 received exercise, education and stress management. Group 2 just education and stress management, and then there's a control group. The first 2 lines are not really surprising. When you measure work and you measure oxygen uptake, the improvement occurs in group 1, the group who had exercise training. The second few lines are surprising, which is when you measure depression or anxiety, the change occurs only in the individuals who had exercise training, not in the group that had education and stress management alone. So it began to create this thinking that exercise itself, and we all know this from the times we go to the gym and you come out feeling better, that exercise itself has a positive impact on mood. And Charles showed this in a formal way. Subsequently, there was a meta-analysis. There have only been 3 studies that have looked at this in a formal way. And as you can see, whether you look at anxiety or depression, there are small but consistent benefits towards the rehabilitation cohort. The next was a study that's been mentioned before, the idea advanced by Richard Gazaburi in California that high intensity exercise, when you measure people pre and post at the same work rate, does result in cardiopulmonary training with physiological adaptations, the most important of which you can see is the fall in lactate for the same amount of work, pre and post training, correspondingly a fall in ventilation. And as we know more clearly today, that would mean a reduction in dyspnea. So that set the stage for early trials of pulmonary rehabilitation. Just showing you a couple of examples. This one is from inpatient rehabilitation. We're looking at the quality of life questionnaire, in this case the domain of mastery. You can see on the left hand side the control group, on the right hand side people who completed an 8-week rehabilitation program, which measurements have been made at baseline, 12, 18 and 24 weeks. And here is a meta-analysis published in the Lancet initially and then updated recently of a number of rehabilitation studies. Here the outcome is the chronic respiratory questionnaire dyspnea domain, and again you can see small but consistently positive effects of pulmonary rehabilitation on dyspnea. This is a slide that Kylie has mentioned, looking at biopsy changes in the skeletal muscle, looking at oxidative enzymes, citric synthetase and HADH, and showing that post-training biopsy evidence of improved oxidative function. So we had this sort of stream of 6-minute walk, quality of life, depression, effects of training, early trials, evidence, biopsy evidence, and then Dennis O'Donnell reported in 4 very, very elegant papers began to draw our attention to this relationship between exertional dyspnea and ventilation occurring in the COPD population. As you can see, a much more steep curve occurring earlier in ventilation, onset of dyspnea, whereas normal individuals exercise and even at the break point at a ventilation above 60 litres per minute have some dyspnea, but it's certainly not the limiting factor. And Dennis began to draw attention to this important relationship between hyperinflation, exertional dyspnea and endurance time. And it's a relationship that served us very well, because what we want to do is improve endurance time, and certain of the adjunctive treatments address the issue of hyperinflation and exertional dyspnea. The last of the studies that took us to the turn of the millennium, or the last 2 I think, is the idea that a bit of rehabilitation is good and more rehabilitation is better. And Thierry Trusters and the group in Leuven showed the impact of longer term pulmonary rehabilitation. Here you can see the change in the 6-minute walk distance following a 6-month program of rehabilitation, a change that is continued for a further 18 months without further intervention. So longer would appear to be better. Tim Griffith published an interesting paper in the Lancet pointing out the diminution of improvement with time. So the left panel shows between group differences between the study group and the control group following 6 weeks of rehabilitation. The right hand side shows after a year, as I think Darcy mentioned, how there is that diminution of improvement. The improvement is still there and incidentally still statistically significant, but you can see just by looking at it the marked diminution. Now what he pointed out, however, and I think it is important, we've been talking about starting rehabilitation programs and convincing administrators to support them, is that the maintenance of economic benefit persisted out to a year. So although the total number of patients admitted to hospital was the same, the number of respiratory admissions per patient fell from 1.9 to 1.4, also the number of all-cause admissions. The days spent in hospital per admission fell from 9 to 6 days, and therefore there was a resource saving as a result of an outpatient rehabilitation program that was extended for 1 year, even when objective measurements of quality of life had diminished very substantially. So that took us to the turn of the millennium. Since the year 2000, there have been a number of fascinating studies that have extended our observations and answered some questions and helped us answer some other questions. Is that for me?
Yes.
That'd be really great. Thank you so much.
It's just water.
It's just water. Sandra, thanks for noticing. The first identifies self-management. Self-management education, Jean Bourbeau, a very nice multi-center trial in Quebec, looking at the impact of patient education in decreasing unscheduled visits both to the physician and to the emergency room. So here you can see in this panel, in white is the usual care group, in red is the self-management group. What you can see when you look at emergency room visits for an acute exacerbation, you see a reduction. You see a reduction in admissions to hospital for an acute exacerbation, and you see a reduction in unscheduled family physician visits as a result of a self-management group. This was a series of lectures given to the patient in their home, and then a case manager available to follow the patient for a subsequent year. There was actually very little supervised exercise in this study. There was actually none. There was one lecture on exercise. Paul Mann and the group in the UK began to point out that early rehabilitation was not only feasible but effective. Now, until then, most of the clinical trials of pulmonary rehabilitation, as part of the enrollment criteria, would insist that the patient was free at least 6 weeks away from an exacerbation. Paul Mann thought differently, and he in fact showed, and on the left-hand panel you see the shuttle walk test, a field test of exercise capacity. On the right-hand side you see the quality of life measure, in this case the St. George's Respiratory Questionnaire. You can see the usual group who have not changed, and the rehab group, that's the left panel, the right-hand side of the left panel, the rehab group where there's a marked improvement in shuttle walk. These individuals were enrolled while in hospital, began their rehabilitation as outpatients within a week of being discharged from hospital. The right-hand panel shows quality of life, and you may recall that the St. George's Questionnaire, a lower column is a better score. So you're seeing the same thing, improvements in quality of life and improvements in exercise tolerance. Martin Sprit and the group in the Netherlands have shown, and this is just an observational study, that if you're admitted to hospital with an acute exacerbation and you look at quadriceps function, and you look at quadriceps function on day 3 and day 8, that there is a fall in quadriceps function, and that it takes about 3 months with no intervention to regain that function. Terry Trusters and the group in Leuven pointed out that you could actually introduce resistance training to individuals during their hospital admission for an acute exacerbation. So you see what's happened here is between day 3 and day 10, they've undergone quadriceps muscle training while they're in hospital, while they're on antibiotics, while they're getting their oral corticosteroids, and without further intervention measured at the end of the month, that is almost 3 weeks after discharge from hospital, that improvement in quadriceps function is identifiable. So that an argument is building for the use of earlier rehabilitation, not just in the clinically stable patient, but in a patient early post-exacerbation. This slide has also been mentioned. It's the concept of dual therapy, which in the mind of the pharmaceutical industry means a long-acting bronchodilator and an inhaled steroid. But another way to look at dual therapy is a combination of pharmacologic and non-pharmacologic therapy, and this slide, which has been described, shows the improvement in endurance time in individuals undergoing rehabilitation who have been maximally bronchodilated compared to those who have not received the same bronchodilation. Now, what about the adjuncts to exercise training? These are modalities that are largely theoretically very interesting. They haven't come into major practice yet. Some of them will. There are probably some phenotypes of patients with severe COPD who would benefit from adjuncts. Clearly not all of them will. If you come to realized, and François Moltet has shown this, that most patients never reach the ideal training target intensity. So this study shows that over a number of weeks in François Moltet's lab, and this is a lab where you get a great deal of encouragement, notwithstanding that, almost none of the patients reached a target training of 80% of predicted maximum. So patients cannot do this because they are so ventilatory limited. So if you come into our lab, this is what you'll actually look like today. You will have electrical muscle stimulation, you'll get some ventilatory support, you'll be given hyperoxia, and you may even get a squirt of Heliox. Actually, this is a theoretical slide. You don't really look like this. So I want to say just a few words about each of those adjuncts. This slide is taken from the group in Yale who published the results of quadriceps, hamstring and calf muscle stimulation, 20 minutes to each leg, 3 days a week for a 6-week period. And what you can see here is the change from baseline, the study group in silver, the sham group in red, and you can see whether you look at leg extension, leg flexion, or a measure of walking, the benefits of electrical muscle stimulation in the cohort that they studied. Supplemental oxygen, this work from Margaret Empner, who is in Sweden, who showed that pulmonary rehabilitation training individuals with supplemental oxygen, even though at rest they are non-hypoxemic, could advance the work rate of training, and so that they finished their training program at a higher training intensity. Constant power exercise, this is just taken from a study of a combination of proportional assist ventilation plus CPAP. It's a study of constant power exercise compared to sham, showing how they can reach higher level of ventilation and exercise for a longer period of time. Exercise training with helium and hyperoxia, Darcy's work by his group and colleagues, showing how if you give a helium hyperoxic mixture, training can be enhanced. So they finished training at a higher percentage of maximum workload. And a newer innovation, the idea of one-legged exercise. That is to say, by reducing the overall muscle mass, you reduce lactate production, reduce ventilation, reduce dyspnea, but you still provide a high muscle-specific training intensity. So here is a slide showing, for us, if we look at peak oxygen uptake with 2 legs, healthy individuals, and then you look at it with 1 leg, obviously peak oxygen uptake is reduced. If you look at patients with COPD, it doesn't matter how many legs they train with. Peak oxygen uptake doesn't change. And the reason it doesn't change is because the peripheral muscles never have a chance to express themselves. There's such a powerful ventilatory limitation that it opens an opportunity for training with 1 leg rather than 2. And here's a slide of peak oxygen uptake after single leg training. You can see the usual care group on the left hasn't changed. You can see the single leg group on the right. There are very few interventions in pulmonary rehabilitation that have managed to improve oxygen uptake. This is a combination of, there are only 2 studies in the literature that have shown this well, and a combination of both, again, strengthens the sense of being an overall effect. So I think in 2006 the advent of evidence-based guidelines was a milestone, because if your professional society is either writing or advising that you follow guidelines, it means your discipline has really arrived. Moreover, there are 2 absolutely superb guidelines. There's the joint American Thoracic Society, European Respiratory Society guidelines, and the joint American College of Chest Physicians guidelines, both of which have provided excellent evidence-based guidelines on tackling rehabilitation, so much so that I would say that there's absolutely no indication for multiple countries to keep writing country-specific guidelines, completely redundant, unless the local circumstances are so dramatically different that you think the guidelines should be different. So we had evidence-based guidelines. And the same year, Casas and colleagues published a 2-country study, carried out in Spain and Belgium, looking at the concept of integrated care along the lines that Sandra was speaking about, showing post-hospitalization. They took 155 patients enrolled immediately after hospital. They gave them a brief self-management program. Then they had a shared care plan, depending on which country it was, either a nurse and primary care physician, or in Belgium it was all done by primary care physicians, and two very important things: a case manager who they could call Monday to Friday during the working week, and a web-based call center which would allow primary care to communicate with the specialists, would also allow the patients to initiate a call if they had a problem. And this is what they showed. That is to say, the probability of remaining free of hospitalization was higher in the integrated care group compared to the usual care group over the 1-year follow-up. A second excellent study on disease management, published by Rice and colleagues, 2010, showed once again, when you look at the number of visits, either the usual care group or the disease management group, you see on the right-hand side disease management, whether it's hospitalization or emergency department visit, this very powerful impact of a disease management program. I mentioned CTS clinical practice guidelines not just because I'm proud to live and work in Canada, but because I think their guidelines have not competed with other guidelines. They're extremely practical, and they said rather than redo this horrendously detailed evidence-based guideline, why don't we ask some very specific clinical questions? And Darcy was the chair of that group. It was a large, very collaborative group, and they asked, these are the questions they asked: is non-hospital rehabilitation as good as hospital-based programs? Does adding resistance training improve outcomes? Does extending the program? These are very, you can read them, they're very clinically important guidelines, and they're quite different because these are clinical practice guidelines that don't compete with the others. And it means that when these guidelines are revised, I'm sure you're looking forward to this, they could ask another 6 clinical questions that have become burning and important to answer. So it's a different approach to guidelines, very worth looking at. So that takes us on the journey from the early pioneers right through to the guidelines and the adjunctive treatments that are still being explored. I just want to say a couple of words about what I think is still to come, and what I hope as you develop your programs here and add the academic component to it, that you'll be able to look more carefully at some of these aspects. First of all, pulmonary rehabilitation beyond COPD is becoming clear, and this is just one example from Anne Holland and group. I think they're Australian, aren't they? Yes.
No.
Well, it doesn't matter. Anne Holland and group looking at interstitial lung disease, pulmonary rehabilitation, randomized controlled trial. As you can see, whether you look at the 6-minute walk distance, measure of dyspnea, MRC score of dyspnea, or measure of fatigue, patients with interstitial lung disease have improved relative to the control group. And here's a summary slide of changes in 6-minute walk distance in a variety of circumstances between pre and post. So you can see Holland, group looking at pulmonary artery hypertension. This is the German group. Patients pre-operatively given pulmonary rehabilitation, post-operatively, and post-lung transplant. So we see a much broader application of pulmonary rehabilitation. In fact, a second-year medical student said to me quite recently, why do you call this pulmonary rehabilitation? It's the wrong term. It's really rehabilitation of the patient with pulmonary disease. Now, I thought that it was a bit impertinent, so I said to him, yeah, my son, you're right. And he's corrected me, and I think he is right. I think it's a much broader field than just pulmonary rehabilitation. We're really tackling the patients with lung disease. I think an awareness of comorbidities is something that requires exploration. Most patients that come into our program have a minimum of 5 comorbidities. I have many, looking at the drug regimens, many have 10 comorbidities. This polypharmacy tracks back to a multiple of comorbidities, many of which are not well controlled, and it might be that for the overall patient to improve, we have to tackle the comorbidities more carefully than we have, and certainly more carefully than were tackled in the early clinical trials where patients with multiple comorbidities were excluded. And here you can see from Crisafulli, this is a group in Italy that have described the main comorbidities: hypertension, coronary artery disease, and of course the metabolic comorbidities, dyslipidemia, osteoporosis, diabetes, as being very prevalent in the population that we treat. Now lastly, and this question was raised earlier on, the issue of the patients with heart failure. Well, cardiac rehabilitation has these two populations: the post-infarct patients who really function at a high level and could probably exercise at the local gym, and the patients with heart failure who are just like the COPD patients in the manifestation of their disease. They are limited by dyspnea and profound fatigue, and they have anxiety. And in fact, when you look at their muscles, what you can see in both the legs on the left-hand side, the arms on the right-hand side, looking at the peak torque controls in red, heart failure in white, and COPD in blue, that there's this dramatic decline, but it's striking how similar these two groups are, whether you look at leg function or arm function. And Rachel Evans last year published some work she'd done in the UK at the University of Leicester, and what you can see here is an exercise rehabilitation program looking at the shuttle walk on the left-hand side, incremental shuttle walk distance, looking at the endurance shuttle walk, a measure of endurance, looking at patients with COPD and patients with heart failure, and showing that they begin at about the same level and they end at about the same level with the same increment of improvement. Now, the issue of survival. For some people it's really a big deal. For me, it's never been a big deal. I see rehabilitation as a quality of life treatment, and so whether it does or does not influence survival, for myself, is not that important. But for the profile of pulmonary rehabilitation, some insight as to its impact on survival can be useful. Well, first I would say we don't know. That is to say, the appropriate, very large, 7-year, multi-center trial has not been done, and it needs to be done. But I just do want to make one or two comments, because pulmonary rehabilitation influences certain things that we know do affect survival. The first is we know that dyspnea affects survival, and you can see here a survival curve looking at grade 1, 2 and 3 dyspnea levels. Grade 4, the number of people is so small, looking at the cumulative percentage of survival based on dyspnea. I don't want to overcall this by saying rehab will influence survival, but you can say that we're aware of the fact that rehab does influence dyspnea. So maybe. If you look at quality of life, here's the St. George's Questionnaire, looking at survival against different levels of St. George's Questionnaire. Once more, what we do know is that rehab influences quality of life. So maybe. We know, for instance, from our cardiology colleagues, the importance of oxygen uptake as a predictor of survival, modified by Victor Pinto-Plata and the group in Massachusetts. You can see here the change in the absolute 6-minute walk distances and their association with survival. Again, I don't want to overcall it and tell you that there's a cause and effect, but we do know that rehabilitation influences 6-minute walk distance. We also know that individuals who are more depressed do not live as long as those who are not depressed. We know that rehabilitation influences depression, and I probably should add one more panel to the slide as to the impact of improvements in peripheral muscle function and their association with survival. So we have at least 5 components that determine survival that rehabilitation can influence. We don't know the answer, but I think it's an interesting story to explore. So in summary, I've taken you from 1980 and projected to 2020. We began with recognition and use by the clinicians in the field, the early pioneers, then to the development of evidence of effectiveness and underlying principles, then recognition by the general medical and surgical community, as in lung volume reduction surgery, now new approaches to exercise training, earlier rehabilitation, its application to other disease settings, other respiratory conditions and other settings, and finally to integrated care, improved management of comorbidity, and perhaps will show an impact on mortality.